Good evening, Akanksha ma'am.
Hello, good evening.
Ma'am, shall we start 7:30 exact?
Yes, we can start.
Ma'am, start kar. Ma'am, shall we start? Akanksha ma'am.
Yes, please, we can start. I think Dr. Jitendra, just remind him, then we can just start because I think he's not.
Yes, ma'am. He will join in shortly.
Yeah, fine, we can start then.
Okay.
Yeah, so can everybody see and hear me?
Yes, ma'am. Good evening, everyone. On behalf of the International Association for Integrated Oncology, IAIO, I extend a very warm welcome to all our esteemed faculty members and participants joining us from across the country. Thank you for being with us for today's IAIO Expert Insight session on decoding lung cancer from detection to decision. Lung cancer continues to be one of the leading causes of cancer related mortality worldwide. So, we are privileged to have an eminent panel of experts who will share their valuable knowledge and clinical experience. Before we begin, it's my privilege to introduce our program director for today's session. It, it gives me immense pleasure to welcome Dr. Akanksha Chaudhary, Consultant Department of Medical Oncology and Hematology, IIMS Bhopal, who is serving as the program director for today's academic session. Ma'am, thank you for taking the time to lead this important discussion. Over to you, Dr. Akanksha Chaudhary, for the welcome address and introduction.
Hello, thank you. Thank you for the kind introduction. And as we all know that today we are going to discuss about lung cancer. It's a very frequently discussed topic in the CMEs nowadays. But the specialities of today's event is that we are going to discuss some topics which are very frequently discussed and other topic which is not so frequently discussed. And we as medical oncologists should definitely have an idea of these topics. One of it is frequently asked in postgraduate, this SS Viva, or even just as important as a theory question. So it will be very useful for all the residents. And other the two topics which we are in which we are going to involve the multidisciplinary approach. One is from a radiologist and one is from a surgical oncologist. So this gives us an extra edge when we know, when we send to a surgeon what they are looking at, what they are going to do next for the tumor. So this is one new aspect that I'm trying to bring in this meet. And also the radiology and lung cancer, which is just growing rapidly in this area of AI. There are some, I told Dr. Jiten to include one of the slides in which we can, differentiate between EGFR and ALK based on CT scan reports. So those are the new things that are coming up. There are studies going on in this regard. So radiology and AI, we should know as a medical oncologist, it's very much upcoming area. And NGS always discussed something new, always to learn. And Dr. Chinu Jomi is there with us. She's worked in Manipal, Bangalore, one of the best centers, which would be really leading ahead in context of NGS and giving the most advanced treatment to the maximum number of patients. So we have best of speakers here and wonderful topics. Hope you enjoy the session. Okay, so here we begin with the first talk.
Thank you very much, Dr. Akanksha Chaudhary, for setting the context so beautifully. We now move to our first scientific presentation. Our first speaker is Dr. Saurav Tiwari, medical oncologist, Balco Medical Center, Raipur. He will be speaking on screening in lung cancer. Dr. Tiwari, thank you for joining us. The virtual podium is all yours. Saurabh sir, over to you.
Hello, can you hear me?
Yes, sir.
Yes. Hello. Hello, everyone. Good evening, everyone. So I'm here to present screening in lung cancer. Can you please share my slides?
Sure, sir. Please give me 2 minutes.
Yeah.
I'll Sir, it's visible?
Yeah. Okay.
Yes.
Okay. So good evening, everyone. So today I'll be talking about lung cancer screening. So we are pulling together the current evidences, the major guidelines, and what's changed recently, especially within the NCCN 25 update. So these are the four guidelines bodies where we are referencing throughout the presentation. Next, please. Yeah. So so here is the roadmap. We'll start with why screening matters at the population level. We'll walk through the two landmarks trial that build the evidence base, cover who qualifies under each guidelines. We will talk about the scan itself and how we report it. It weighs benefit against harms and touch on the shared decision making and close with where the field is headed. So next, please. So, as we all know, the lung cancer remains the number one cause of the cancer death, both in the US and worldwide. The data shows here is specifically showing about the US. So, in US, it's showing the 24 data where approximately about 24 data we're looking for, like it's roughly approximately 234,000 new cases and 125,000 approx death in US alone. If we talk about in India, the lung cancer account for approximately 6% of all cancer. That goes approx 80,000 and 75,000 death. That about the Globocan 22 data. And in USA, the median age of diagnosis is about 70 years, where smoking drives the most of the cases, and it has the 20-fold risk. And we talk about in India, it's lung cancer typically diagnosed. The median age is 65%. So the true trials where anchor everything we do is the NLST, which is from US, published in NEJM 2011, and Nelson from Europe, which published in 2020. So the NLST randomized, as you can see, that randomized over 53,000 people with the age of 55 to 74, with at least 30 pack year to the LDCT versus or the chest X-ray, tested LDCT against another imaging test, not against nothing. In Nelson trial, as you can see, it used as a true no screen control arm was there, and it shows in NLST trial, it shows approx 20% relative risk mortality reduction And in Nelson, as you can see, it shows relative risk reduction more in female compared to male, which was in the subgroup analysis. So in male, it was approx 25%, and in female, it varies from 40 to 60%, which is smaller, less powered, but in subgroup analysis, it showed more towards the women. In NLST, it is the category 1 evidence, and Nelson carrying is the largest trial with the genuine and screened comparator. So together they are why every major guidelines are endorses annual LDCT. Next, please. So, who to screen, and the most clinically useful slide is because there are the three guidelines which we can show. So here is the USPTF, which is 2021, and the other one is ACS 23, and NCCN, which is recently updated. So in age ranges, it's showing almost same for the 50 to 80 years carrying. In NCCN, it is carrying 50 years as well as more than 50 years, where there is no upper limit. Everyone is carrying for the smoking history with more than 20 pack years. Recently, NCCN accepts more 20 years of smoking duration, which is a category 2B recommendation where there is no pack year method needed. So for quit year, US PSTF still requires quitting within 20, 50 years, 15 years. ACS and NCCN has been eliminated that cutoff entirely. So there is no cutoff criteria. For the upper age limit, US PSTF and ACS stops at 80, but NCCN recommends for like there is no upper limit. It based on the functional status of the patient and the curative treatment of the candidate. So all three required shared decision making before the first scan. The next one. Next slide. Yeah, so we are basically following the NCCN 25 update. So there is like four major updates, which is there is no upper age limit. It removed in 21. If a patient can tolerate both the curative intent therapy, age alone doesn't disqualify them. There is the second update is 15-year quit restriction. It removed in 22. Risk stays even more for more than 25 years, which is 3x higher than the never smoker patient. The new thing which is added in 25, it was 20 year of smoking duration, which is added. There is no pack year needed, so it matters for the equity because there is for both black and white patients. So it average for the fewer pack years than white, because the black patient averages fewer pack years than white patients for the same risk. And the fourth was the shared decision making. It mandatory before a first scan. So there are various risk calculator through which NCCN endorses this shared decision making. The next slide. Next slide, please. Yeah, so this is the actual guideline of NCCN. As you can see, there is the algorithm which is shown: risk assessment on the left side, stratification on the middle, and the screening pathway on the right side. The key split is very simple. If the higher risk, there is high risk, goes to a benefit and risk discussion, and then LDCT. For the lower risk and under 50 or under 20 pack years or less than 20 years of smoking, any screening isn't recommended for them. So this is for the full risk assessment input, which is all listed here. The next one. Next slide, please. Yeah, so this is the actual LDCT technique. LDCT, there is a low dose CT, which means low dose, which have the 0.65 to 2.36 millisievert per scan, which is actually very less than the annual background which a person can achieve throughout the year. So, and no IV contrast needed for the screening. And findings are reported using lung rats, which is ACR standardized system. It updated in 2022, where you can see the category 1 and category 2 negative and benign, which needed annual LDCT. For category 3, it's probably benign, which needed 6-month LDCT. For category 4A, it's suspicious, then every 3 monthly required. For 4B, it's very suspicious, and 4X as well as very highly suspicious. So we need go for the diagnostic workup. And there is like for very high speed triggering for the other factors, like we are going for the diagnostic CT chest scan, PET scan, or the tissue sampling, or the specialist evaluation as per the management for the nodule. The next one. So here we can see that there is a no screening test which is harm-free. So there is like 20. What are the benefits we can see? There is 20% mortality reduction as per NLST study, and up to 60% as per Nelson, as we can see, which is very much higher in the female subgroup. And there was a real stage shift toward the earlier, which we can have the more treatable disease. And what harms we were having, it was there was a false positive rate over a quarter at baseline in NLST, down to under, which was 13% with the lung rats, and about 1.7% of NLST patients had unnecessary invasive procedure. There was overdiagnosis, a recognized downside. So only about 18% of the eligible people in the US were screened in 22. The evidence is the bottleneck, it's just the implementation. So the takeaway is like the USPS TF calls it, this is a moderate net benefit. So concentrated in the truly high risk population, which is exactly why eligibility criteria and shared decision making matters so much for us. The next slide. Yeah, so this is like what is the shared decision making and risk calculation. There are various risk calculators other than age, and like there is like passive smokers having this other like discussion benefit and harms with the real chances of false positivity. So screening is not a substitute for a quitting smoking, and whether the patient would want treatment if something were found. So the risk calculators we were having are Tamagagi, back models, LCDRAT risk calculators were various. So mainly in NCCN they follow is Tamagami and PLCO M2012, which NCCN endorses. It factors in included the BMI, COPD, family history. In PanCan study, it found that 77% of the early stage cancers versus 57% with NLST criteria alone. Other two are BAC and LCDRAT are the research and modeling alternatives. And for everything, smoking cessation must be offered to the every current smoker, because screening should never be framed as the permission to keep smoking. The next one. So as we have found, like there is a criteria for who we can screen. There is also like who should not be screened. So there are like the major thing is if someone is having symptoms like cough, hemoptysis, weight loss, so there should be diagnostic workup. It should not go in the screening pathway. And if someone is having prior lung cancer, then obviously it will go for the surveillance protocol, treatment, and another thing. And anyone who could not tolerate or would not want the curative treatment, the entire benefit depends on being able and willing to act on a finding. If there is a finding of a nodule, then how it will be created. So there is always shared decision making. And a person, if someone is having severe COPD or heart disease, it will not automatically exclude them. So there we will always have this shared decision making if we can go ahead with the screening or not. And and there are like never smokers, they always falls outside the guidelines. There is no randomized control trial data yet for these patients. The next one. So there are like this is where the guideline decision, the actual equity in lung cancer screening, what are the racial disparities and guideline responses. This is the real world consequences. In old 2013 USPSTF criteria, only 17% of the black smokers were qualified versus 30% of the white smokers, even though the black men have the higher incidences at the same smoking exposure. Why? Because the black patients accumulate fewer pack years on an average, about 16 versus 22 in white patients. So a pack year cutoff was quietly excluding the higher risk group. So how it fixed it? So USPSTF dropping the threshold from 30 to 20 pack years in 21, which roughly doubled the black men eligibility. And in NCCN new duration based criteria in 25 is direct continuation of that equity driven correction. So the guideline threshold aren't just clinical parameters, they have a demographic impact as well. As that's how the part of these guidelines are being revised every another year. The next one. So where we are heading in future directions and emerging evidences, there are like where we can see like liquid biopsy, ctDNA, they could help the triage who need LDCT or not. Currently, they are not FDA approved, but they are in the pipeline. And AI and computer-aided detection already being built into nodule detection workflow. Risk model-based screening, like trials like ILST testing, where PLCO M2012 outperform simple age with per pack year cutoff. There are other like European implementation underway, but uptake around 5% in the most country. The next one. So the main key takeaways from this is like annual LDCT is the only evidence-based best test category 1 across all three bodies. Core eligibility is 50 plus age with the 50 plus with the 20 pack years of smoking history, and NCCN also accepts if the person is smoking for more than 20 years. And 15 years quit smoking limit has been vanished from the NCCN and ACS. NCCN alone also has there is no upper age limit. Lung rats 22 is a current reporting standard. Their cuts for the false positive rates. Mortality benefit was approx from 20% to 60% with relative risk reduction. So roughly approx 48,000 US deaths per year preventable if all eligible patients were screened. Guideline changes have majorly improved equity for both all kind of like Black and Hispanic patient. Shared decision making with smoking cessation required before every first scan. So this is the end of the slides. These are the references. Thank you everyone for listening.
Thank you, sir, Dr. Saurabh Tiwari, sir, for that insightful presentation highlighting the importance of timely screening and early detection. We now move to our next expert session. Our next speaker is Dr. Jitendra Sarma, Associate Professor, Radio Diagnosis, AIIMS Bhopal. He will be presenting on lung cancer imaging. Dr. Sharma, we are delighted to have you with us. Over to you, sir.
Hi, thank you, Dr. Sapna. Is my screen being shared? Is it visible to you?
No, sir, not yet.
I have sent the request for sharing a screen. I think you have to.
Can you please send it again, sir?
Yes, now it's showing. Yes. Is it visible now?
Yes, sir, visible.
Okay. So my topic for today was imaging in lung cancer. I would be covering how to stage and how to screening part is already covered in the recent updates in the imaging. So as we know that this is the world and the India status of the lung carcinoma, it is topmost cancer in the worldwide and fourth on the Indian outline. And these are the number of the incident cases. And this slide shows the high mortality, almost out of 2.4 million cases worldwide. It is 1.8 million cases are dying in the world level. So just a side note regarding these graphs, I visited this site. Obviously, many of you must be knowing this site. This site helped me prepared in creating demographics data. So regarding the imaging part, imaging plays a very central role. Initially, it picks up the diagnosis of the case and also helps in the staging. Then it helps in the either taking the biopsy and if not possible, then planning for the biopsy. As Sir Dr. Saurabh described that radiology is also involved in doing the screening, that is lung rats part, and also the response assessment in the following of the treatment. So these will be my agendas for today's class. I will be briefly covering the recap of recap of the classification and the imaging features. Then I will be covering about the TNM staging, the recommendation on the imaging protocols, recent updates, and a little bit about radiogenomics. So to recap, the WHO has in 2021 has classified on basis of the HPE, which is a very complex classification system. They also divided on the basis of whether the diagnosis was made on the basis of biopsy or it is a surgically resected specimen. So to make it more simpler for from radiological or imaging perspective, we can divide it largely. There are two groups of the lung cancer, non-small cell and the small cell. In non-small cell, majorly there are adenocarcinoma, which is the most common type. Then there is squamous cell, which is the second most common type, and there is large cell type. And the 15% of the lung cancer cases are small cell cancers, while rest 5% or 7% cases are made up of other rare tumors. If we look at the location, then The central or the perihilar location is common with squamous cell carcinoma and small cell carcinoma, and peripheral location is more common in adenocarcinoma cases. Regarding the imaging modalities which are available, the X-ray and the CT scan, they are foremost in the beginning. At the beginning of the disease, they are used for the pickup of the cases, for initial diagnosis, and for getting a biopsy done. PET-CT is required for non-cerebral metastatic workup, and MRI is recommended for it is the investigation of choice for looking for cerebral metastasis, especially the post-contrast sequences. Without contrast, plain MRI is not very much useful for picking off brain mat. So that was the key takeaway point from that. Usual imaging features, we can see a nodule in form of solitary pulmonary nodule or SPN. We can see a mass, a consolidation, a cavitatory lesion, or evidence of metastatic disease. We can also have indirect signs in form of secondary mass effect of the primary mass. Just to show a few examples, here we have this a relatively ill-defined lesion in the right lower thorax, which on CT showed spiculated margin and biopsy showed confirmed adenocarcinoma. In this case, we can see the hidden zone of the lung, that is the retrocardiac part of the left lung, where a lesion is very faintly visible, while on the lateral view, this lesion is relatively well seen. And CT again showed an spiculated margin SPN lesion, which confirmed on biopsy as adenocarcinoma. In this X-ray, the initial X-ray, an opacity was identified in the right lower lung zone, and that got partially resolved in a follow-up X-ray. And when a CT was done, they found a nodule in the bronchus with subsequent secondary atelectasis that turned out to be a carcinoid. Another case where a haziness or an opacity in the left lung is seen, and it was followed up after 12 months, and this haziness has increased. So further biopsy revealed malignancy here. In this initial X-ray, the right upper lobe collapse was identified, and a suspicious nodule was identified in the left mid-lung fields. And a CT revealed this nodule to be a metastatic in the left side and a hilar mass with subsequent upper lobe collapse. This is to show that how the bone suppression algorithm can help. Here the lesion is very faintly visible, but as we apply the bone suppression algorithm, we can see the lesion very nicely in this case. This is an example of benign lesion, how the lesion remains stayed same after subsequent follow-up of after a year. So those were some common imaging features. Now move on to more specific features. First is the adenocarcinoma, which is the most common type of lung carcinoma, which comes from the group of NSCLC, that is non-small cell, constitutes about 45% of the cases, and most common in the non-smoker and young patients. It is usually presented as a peripheral solitary pulmonary nodule, and having this ground glass opacity is a hallmark of this cancer. It can present as a pure ground glass opacity or GGO nodule. It can present as a pure solid mass, or it can present as a partial solid, partial GGO mass. And overt consolidation and cavitation are usually not very common. So these are the WHO defined classification of adenocarcinoma. It can be in pre-invasive state, then invasive state, and invasive type of carcinoma are of two types: non-mucinous, which is most common, and then mucinous type. So usually the hallmark is same. They have some type of ground glass nodules or ground glass opacities around the solid nodules. WHO has also identified these adenocarcinoma in situ and minimally invasive adenocarcinoma and lipidic predominant. These are the histopathological type which are identified as a predominant pattern on histopathology, and they manifest as a predominantly in the form of GGOs on CTs. So that GGO pattern has been described as a lipidic growth counterpart of the pathology. While this mucinous variant of the adenocarcinoma, they are rare and they are very aggressive, and they present as a multifocal bilateral mass-like, solid mass-like lesions. So there are a few examples of various types of adenocarcinoma. This is adenocarcinoma in situ, a pure GGO nodules. We can see here. This was in case of minimal invasive adenocarcinoma. We are seeing a solid nodule with surrounding ground glass opacity. This was a lipidic predominant mass where we can see a large patch of ground glass opacity with consolidation areas. And this was an aggressive mucinous adenocarcinoma. where we can see this large solid lesion here. So moving on to next case, these cases were taken from Radiographics, recently published articles, and we can see multiple bilateral, multifocal, peripheral ground glass opacities with solid nodules. So this was a case of invasive mucinous type of adenocarcinoma. So this was a clarification further explored in this article, that how to measure this adenocarcinoma lesion. If a lesion is pure ground glass or pure solid, you have to measure the entire length of the lesion. However, in subsolid lesions, you measure only the solid part of the lesion for all the staging purpose and follow-up purposes. This GGO part, this represents a non-invasive growth along the surface of the alveoli, while the solid part, it represents the true invasive growth. So we measure the entire part of the lesion, but we only consider the solid part of the lesion for all staging purposes and to include in the RECIST criteria. Another adenocarcinoma in the left hilar region, we can see it is a solid and part solid, part GGO lesion. So that was adenocarcinoma. Second most common is squamous cell carcinoma. They are usually central or perihilar in location, commonly associated with smoking. And they involve the mediastinum very early. Since they are immediate in the hilum, they have more mediastinal hilar lymph node involvement. And the hallmark feature on CT and imaging is having a cavitation, which is seen in 82% of the cases. And since they are central or perihilar in location, they are usually associated with secondary features of lung collapse. Here we can see this large consolidation area with central cavitation in the right lobe. And we can also see this bulky right hilum and this deviation of the this increased subcarinal angle. The CT confirmed presence of a cavitatory mass with multiple subcarinal nodes. So this came out as a squamous cell carcinoma. Another example of squamous cell carcinoma can be seen here. A left upper lobe mass with huge amount of cavitation and a good amount of enhancing tissue at the periphery of its wall. Another case, the chest X-ray is showing this perihilar haziness in the right on the right perihilar region, and the CT confirmed this large mass in the perihilar location with confluent infiltration of the mediastinum. Another case of perihilar squamous cell carcinoma, where the mass is frankly infiltrating the mediastinum, making it a T4 disease, and frank vessel infiltration was also there. So the third most common type of lung cancer is small cell lung cancer. They are very most aggressive tumor. They are usually associated with paraneoplastic syndrome, and similar to SCC, they have this hilar and perihilar location, but they have more infiltration of the mediastinum. They are more aggressive. So at the time, sorry. So at the time of presentation, they have more lymph node involvement and more aggressive involvement of the mediastinum. In the CT, we can see this perihilar mass here, which was involving this immediate left lower lobe left primary bronchus, and this mass was also infiltrating into the mediastinum. This turned out to be an SCC. Another example of very aggressive infiltrative kind of SCC, which has filled the entire right lobe, frankly infiltrated the mediastinum. Even then, there is involvement of the IJB, the complete SVC obstruction. So this shows the severity of the disease, that SCC are usually very large and infiltrative at the time of presentation. Other relatively less common type is large cell NSCLC, which does not have a very typical imaging feature, and usually they are peripheral and heterogeneous mass. So this is an example of large cell NSCLC, where you see a non-specific feature of a large mass infiltrating into the mediastinum. There are some other less common variant. As we can see, there is a carcinoid with distal atelectasis. This was case of a pleomorphic sarcoma. These are usually a very less common tumor, accounting for less than 5% of the tumor. So moving on to next part is the updates in the TNM staging. This was proposed by AJCC in 2023 and came into effect from the January 2025. So the major changes were in the N2 and M1C category of the 8th TNM. So if we look at the 8th TNM, the T1 was 3 centimeter or less. So these measurements, they were on the solid part of the lesion, and that was measured on the lung window. So on the pure GGO or in the pure solid lesion, the entire lesion was measured, and the part solid lesion, only the solid part was measured. So on the basis of those measurements, T1 is less than 3 centimeter, T2 category is 3 to 5 centimeter, T3 is 5 to 7 centimeter. and T4 is more than 7 centimeter. These are the size criteria. Other than this, if the tumor is directly infiltrating into the mediastinum and the mediastinum structure, it immediately becomes a T4 disease. While if the tumor is involving the peripheral structure like phrenic nerve, parietal pleura, or parietal pericardium, it becomes a T3. Also, that's important point to note here that if there is a separate nodule from the primary tumor in the same lobe of the lung, it is a T3. And if there is a separate nodule in the same lung but in a different lobe, it becomes a T4. The important part is to here that you have to measure the solid part only in part solid lesions. So regarding this N category, in the 9th TNM, the N2 category has been further elaborated. We will just try to cover this in this image. So if there is a mass in the right lower lobe, so all the lymph nodes which are intrapulmonary, peribronchial, and inferior pulmonary hilum 11 and 10 station, they would be considered as N1 group. All the lymph nodes which are having in subcarinal label or on the ipsilateral side of the mediastinum, they would be considered an N2, and all the contralateral hilar lymph node and contralateral mediastinal lymph node and all the supraclavicular lymph node, they would be considered as N3. So this N2, this has been divided in TNM 9th staging in two parts, that is N2A and N2B. N2A is when there is only single station is involved, and N2B when there is multiple station involved. Meaning, if we are having only one ipsilateral mediastinal or hilar node, single station, then we will call it as N2A. And if we are having multi-station lymph node on the same side, it will be called N2B. And it is the number of the stations are involved which is important, and not the actual number of the lymph nodes. Other than all these lymph nodes, rest of the lymph nodes, they are considered as a distant metastasis. So moving on to M classification or the metastatic metastasis grading, the TNM 9th has divided this M1C into M1C1 or C2. So what is, let's try to understand this on this image. So initially, as I described, if we are getting a separate nodule in the same lobe, it would be considered a T3. If we are
Sorry
getting
to interrupt, sir. Sir, 2 minutes left for the session.
for my session,
Yes, sir.
I thought that my session was for 30 minutes. Okay. So anyway, so
Okay,
this
you can take some more time, Dr. Jitendra. We will try to squeeze the later
Acha,
session.
let me know when it's
Just make it a
better time
little
to go.
less, not
Yes.
yeah.
Yeah, so
Can you finish
this
it?
the separate nodule in the different lobe becomes an T4. Regarding M1A is multiple contralateral tumor nodule, M1B is single extrathoracic metastasis, and M1C 1 and 2 are multiple extrathoracic metastasis single organ, and multiple extrathoracic medicine are different organs. So let's these are some classification. These are some examples of how to use this TNM staging. Again, this is a T3 disease. Then this is a separate nodule in the different quadrilateral lung. This is become an M1A. And moving on to this is T2A and 2A, multiple stations, single stations. And this is N3 disease. We are having contralateral lymph nodes. This is M1C1, all the mets in single organ system, different organ system M1C2. And this is how the brain mets looks. So these are recommendation on the imaging protocols. So regarding this NSCLC, contrast enhanced MRI of the brain recommended in stage 2 and above, or if the stage 1B lesion is more than 5 centimeter for extracerebral metastasis. While in the small cells, since they are aggressive tumor, contrast enhanced MRI of the brain is recommended in all cases, irrespective of the stage, and including the CECT of the pelvis also. So these are the few signs. This is a recent paper where this researcher has established the 3 signs which suggest higher chances of occult lymph node metastasis. This is an inner margin ratio, higher inner margin ratio than this lollipop sign. This presence of these signs, they suggest higher chances of lymph node metastasis in early NSCLC, and this is a broad plural based relation. So moving on to this molecular marker part, these are multiple markers have been introduced in recent WHO 2021 classification. And the radiology, the imaging also has tried to catch up with this imaging features of these markers. One of the important and interesting marker is the PDL1 expression, which is on the at present targeted immunotherapy can also be delivered. However, there is no specific imaging features for PDL1. Regarding the most common one, the EGFR mutation, the usually found radiological features which were found in this EGFR mutation positive were multiple ground glass opacities, presence of air bronchogram, pleural tracking and retraction, and the vascular convergence signs. So these are the signs as we are seeing here, multiple GGOs, opacities, and this pleural retraction. So these are the signs which are commonly seen in this EGFR positive cases. Other mutation which are the EGFR mutation which were commonly studied were exon 19 deletion and exon 21 deletion. So exon 19 deletion, they have large tumor size, more solid component and fewer ground glass components. While the 21 deletion, they have a better recurrence after resection. So this was a case of exon 19 deletion where they found were multiple miliary metastasis in the lung and also in the brain. ALK mutation was also studied for radiological imaging, and they found that the ALK mutation tend to have more solid lesion. They were central in location. Since they are central, so they don't have a pleural tail. They can have a large lymph fusion and lymphangitic carcinomatosis. There's another case of ALK positive adenocarcinoma where we have the central mass with distal collapse. KRAS mutation was also studied, and the tumor which were KRAS positive, they were found to have less solid and lower frequency of lymphangitic carcinoma, but a higher frequency of brain metastasis. This was a case of KRAS positive mucinous adenocarcinoma, where we can see multiple peripheral ground glass opacities. ROS1 fusion, the imaging features which were found to be were similar to the ALK mutation. However, the lymph nodes were found to be more extensive in the ROS1 fusion positive adenocarcinoma. MET exon 14 mutation was found to have large necrotic lesion in the perihilar locations. So those were some features which were studied in detail, but the road ahead is the radiomics and doing the radiogenomics, which is the AI-based application where we extract the imaging features and try to predict the prognosis as well as the genetic nature of the disease, nature of the tumor. The any deployable model is still not available. They are still in the development phase. Most of these studies they have done on the EGFR and the ALK positive ALK mutations, and the PDL1 mutation are being studied upon to find out the specific imaging features. And these LCI rats and the post-treatment LCI rats, they have been developed. So the lung rats, this has been covered, the screening part has been covered by Dr. Saurabh. So we try to keep the MA on the lower side to keep it lower dose. And just to take home, the take-home message from this, my short presentation is to get an accurate TNM staging done based on the imaging. And while following up the patient, you have to keep in mind the treatment-related complications, which are more common in the targeted immune therapy patient, like organizing pneumonitis and related pseudo-progression also. Nowadays, the era is of the radiomics and the radiogenomics, using this available radiology image bank and developing AI models to predict the genetic behavior and the prognostic nature of the disease. So that was my presentation, and these were my references which I have used. So thank you, everyone, for patientful listening.
Thank you, sir, for that wonderful presentation. So now we move forward to the surgical perspective. It's now my pleasure to invite Dr. Nilesh Srivastava, consultant surgical oncologist from Nagpur, Maharashtra. He will be speaking on role of surgery in locally advanced lung cancer. Sir, the platform is yours. Over to you, sir.
Am I audible? Am I audible?
Yes, sir, audible.
I am trying to share my screen. But option is not coming, I think. Can you play my slides? I have, I think, mailed you also.
Yes, sir, sure.
Yeah. Good evening, all. Although I have invited for a small talk on this one, and for management of lung cancer, specifically in locally advanced non-small cell lung carcinoma. So we are going to talk here about the only for adenocarcinoma or squamous cell carcinoma, not for small cell carcinomas. So we will start from from the first slides only. That what is the fully advanced non-small cell lung carcinoma and how they have to be treated. I am not going in detail for stage second and stage first, because we all know that they can go for upfront for surgery, either lobectomy or bilobectomies, depend on the locations of the tumor. So in stage 3 is the specific stage where we have to intervene and where we have to think of, can we give a chance? As a surgical oncologist, I would be more interested in stage 3, where will be my role for doing for surgeries or not. So stage 3 disease, how it will be classified? It is classified if it is either T3 or T4 lesion, or either nodes, bulky nodes there, or either N2 or N3 disease is there, if it is involvement is there. So it is a heterogeneous group, and not all stage 3 cancer patients are same in lung cancers, and their survival range from around 36%, 13 to 36%. In upcoming 5 years, we are expecting that around 30 to 40% they will survive if they are receiving multimodality treatment. So that key point for these slides, that all stage 3 does not automatically means that they are inoperable. Next slide, please. So I will come here, just I will compare the two eras. Previous era where the thinking of, I am not telling the conventional surgeons, but surgeons previously they were thinking before the inventions of the multimodality treatment, and what is the current era, and what is the recommended treatment now, and what we are following. So the thinking is slightly different. Previously, what was the thinking? Resectability, we have to decide on the basis of just anatomy. Is it in upper lobe, middle lobe, or lower lobe, or nodes? Is it resectable or not resectable? Even in stage 3. N2 disease, usually we supposed to do, if it is N2 bulky mediastinal node, opposite side disease is there, it is generally inoperable. And treatment, either they have to prefer, if we are able to give the R0 margins, and if we are able to resect the treatment nodal burden, definitely surgery, or either we have to subject the patient for chemo radiation. So these two modalities was available previously for the stage 3 lung carcinoma. Now what is the newer recommendation? What recently we are following? It is not only the disease which have to be treated on the basis of anatomy. It is the disease which has to be treated on the basis of anatomy, not only the anatomy but the biology of the disease also, and the patient fitness, is the patient is able to tolerate the disease procedure or not. Second thing, N2 disease, it is not like that, like previously we supposed to do that N2 disease is there, patient is not operable. Now newer modality is there, multimodality treatment is there. Selected cases can benefit with surgery. In such cases, treatment, combined multimodality treatment is the recommended treatment in the newer era. So always and always, from this slides, I want to give one message: stage 3 cancer, locally advanced carcinoma, do not take the decision by your own. Always keep the case in multidisciplinary tumor board or multidisciplinary team and make a plan. Next slide. So the question will come: does the surgery help? Answer is yes. I have quoted one study here. Although this is a retrospective study, it is done in New York, but it is done recently in 2025, and they have included around more than 44,000 patients, and they have included CT3 T4 disease and N2 disease, CT3 T4 primary tumor size, and N2 nodal disease. And what surprisingly they have find out, although that is for a very selected and limited disease, limited subsets of the patient like CT3 or N2 disease, they have find out that median survival is comparatively high in surgical group. It is around 51 compared to 25 months in chemo RT group, and death risk is 41% lower compared to chemo RT group. So surgery offer a survival advantage in carefully selected patients. So this is a retrospective study. I only quoted here to just show that even in stage 3 we can attempt a surgery, but it have to be applicable for a selective group. I am again telling, it have to be applicable or not only for the nodal burden, it have to be combined with nodal burden and the primary stage. Next slide, please. So thing is that again I am telling why this era is changed. Why this thinking is changed? Old thinking versus new thinking. This is due to advancement of immunotherapies. Although all our surgical, all our medical oncology colleagues is here, the invention of neoadjuvant the inventions of immunotherapies is a game changer in the management of lung cancers. So we all know that there are some trials like Checkmate 816, Keynote 671, and some meta-analysis there who have shown that in such cases, stage 3 disease where we are including chemotherapy with immunotherapy, definitely response rate is high. PCR is as much as we can get up to 38%, and benefit definitely surgeons would like to get R0 margin, and one meta-analysis is showing we can take R0, we can get R0 margin up to 90%. So this game changer immunotherapy, according to the targeted mutation, is really a game changer for us for managing such type of stage 3 cancers. Next slide, please. So who should get surgery? Which patients is having more favorable factors in this locally advanced carcinoma or in this stage where we can attempt a surgery, and in which are unfavorable factor where we should not go for surgery? So here are some factors which I want to quote. Favorable factors, like if patient is having limited N2 disease, one node or two node or one station or two station, if they respond to neoadjuvant, either new combinations of immuno and plus chemotherapies, if they are having good performance status, ECOG 1 or ECOG 0, and there is possibility of lobectomy if we are going for lobectomy, or able to get the R0 margin. These are the criteria where I can think of, or I can attempt surgery in stage 3 cancers or locally advanced lung cancers. But where I will keep my hand back, where I have to think of, and where I have to be more careful by attempting a surgery, if bulky nodal gestation is there, N2 is there, if disease is progressing, even of chemo and immunotherapies, if patient is having poor fitness or poor performance status, if patient is having multiple comorbidities, if it is diabetes is not controlled, non-case of CAD, and patient is a non-hypertensive, non-uncontrolled hypertensive, multiple comorbidities there, I will be think of before going for major surgery. Or I will think of, if the giving in for giving R0 clearance, it is coming in exchange of pneumonectomy, I will definitely think of to not to attempt for surgery, and it is an unfavorable factor for in such a case, in such a stage. Next slide. So practical surgical trips from my side, preferred is like lobectomy or sleeve resection in stage 3 selected patients. Avoid pneumonectomy if possible, because after pneumonectomy it is very difficult for the patients to accommodate the cardiorespiratory reserves. Nodal disease, definitely more than 3 mediastinal nodes is there, more than one Hyland nodes is there. We would love to avoid the surgery. Minimal invasive surgery, always we will prefer. We will love to do with VETs. And high volume centers, which is doing more than 150 surgeries per year, is having definitely better outcomes. Next slide, please. So after surgery, in such case, what next? Suppose persistent nodal, you have operated the stage 3 cancers, locally advanced carcinomas, and you have found it out that even after surgery, that patient is having persistent nodal disease. Even within 1 month, patient is coming with nodal disease. We would consider for adjuvant immunotherapies, whatever they were receiving. I think that have to be continued, or again we have to do the markers, and according to that we have to start the immunotherapies. If there is no any residual tumors in final histopathology, PCR is there, we would love to observe, and we will not start any treatment. If EGFR mutations is there, adjuvant TKI we can start according to the receptor status. And if positive margin is there, suppose we have done lobectomies or bilobectomies, and if R1 or R2 margins is there, definitely we will go for post-operative radiation therapy in such cases. Next slide. So what guidelines we are following, or what is our institutional policies? What we are following, if patient is coming in stage 3 non-small cell lung carcinoma, if he is fit for surgery, definitely we will put the case in multidisciplinary tumor board, what I quote previously in my slides. And then in that we will discuss, we will see the radiological investigations, the performance status, and we will see is RGO resection possible or not possible. If it is possible, definitely we will consider patient for neoadjuvant chemo or immunotherapies, and then we will reassess. And if patient is coming in the category of surgery where we are getting R0 margin, we will go for surgery, and after that we will use the adjuvant therapy. But if the patient in stage 3 disease where we are not able to achieve the R0 resection margin, we will send the patient for chemo radiation therapy. And after that, if there is suboptimal response is there, patient will put onto the durability for maintenance. Next. So from my side, takeaway message is there that in this case or in this specific scenario, locally advanced carcinomas, always multidisciplinary tumor discussion should be there. Medical oncologist, surgical oncologist, and radiation oncologist, the combined team approach should be there, and they have to make a plan before going for any treatment. N2 disease is definitely, if N2 disease is there, it is not a sentence that patient is inoperable. Definitely, you have to select the patient wisely. Single station or 1 or 2 nodes is there, you can take a chance. T3 disease, N2 disease, 1 or 2 nodes, you can take a chance for surgery. Neoadjuvant chemo immunotherapy, definitely, if it is a if patient is not coming in our criteria for surgery, definitely we would love to give neoadjuvant chemo immunotherapy, and then to love to reassess and then plan for surgery. Surgery improves survival if we are taking patients or selecting patients carefully, and definitely high volume centers is having a good outcomes. Next. Thank you.
Thank you, Nilesh sir, for sharing your valuable surgical insights and practical experience. We now proceed to the final scientific talk of today's program. Our final speaker is Dr. Chinu Jomi, medical and hemato-oncologist from Siliguri, West Bengal. She will be presenting on molecular testing in lung cancer. Ma'am, thank you for joining us. Over to you.
Hi, good evening, everyone. Am I audible?
Yes, ma'am, audible.
Can you share my slides?
Sure, ma'am.
Yeah, so we will be discussing a little bit about the molecular testing in non-small cell lung cancer. My presentation is basically based on the NCCN guidelines. So next slide. So biomarker testing eligibility in NCCN previously was only limited to stage 4 non-small cell lung cancer, mostly for adenocarcinomas. But now the recent recommendation states that even from stage 1B, we need to test for at least EGFR, ALK, RET, and PD-L1 as per NCCN guidelines to decide on the neoadjuvant and adjuvant as per the stage. And from stage 4 onwards, a comprehensive biomarker testing for all eligible patients. So as we know that there are two common non-small cell lung cancer varieties, that is the squamous and the adeno, the non-squamous. So basically broad profiling is required for with a minimum of 10 biomarker panel is usually recommended for non-squamous, that is adenocarcinomas. Previous NCCN guidelines have stated that for squamous, there is no need for molecular testing, but now the recommendation is to test for all eligible patients, especially consider when they are non-smoker, never smokers, small biopsy specimen, or mixed histology when coming to squamous cell carcinoma. So I generally prefer to do limited panel NGS for all my patients of non-small cell lung cancer, irrespective of the smoking history and the histology. Next slide. So depending upon the type of biomarker, there can be two types, that is the predictive biomarker and the prognostic biomarker. For example, predictive biomarkers are those in which the biomarker indicate the therapeutic efficacy. That is, there is a direct interaction between the biomarker and the therapy on the patient. For example, ALK. If ALK is positive, we usually consider for ALK inhibitors. EGFR, ERBB2, KRAS, etc. Prognostic biomarkers are those in which the biomarker, if they are positive, it indicates the innate tumor behavior. For example, if KRAS mutation comes positive, it indicates a poor prognostic survival compared to a patient with a wild type KRAS, independent of what treatment we are giving. So inherently, these tumors have a bad biology and they generally tend to progress faster than a patient without a KRAS mutation. Next slide. So the minimum recommendation as per NCCN is to send for a 10 minimum gene, that is a limited NGS panel comprising of ALK, BRAF, EGFR, HER2, KRAS, MET exon skipping mutation, and the fusions of NTRK, RET, ROS1, and PDL1. MET exon skipping amplification is now considering as a high-level emerging biomarker. So as per NCCN guidelines, the biomarker testing must be performed at properly accredited laboratories. That is, a minimum of CLIA accreditation is recommended for these labs. Next slide. So the main problem we face when we test for a lung cancer NGS testing is the tissue limitation. So usually lung biopsies, there can be a very 1 core or maximum 2 cores available. So the tissue limitation is the major problem we face, and in that, if it comes as a poorly differentiated carcinoma, we need the tissue for IHC to know whether it is adeno or squamous, and then again, if the tissue is remaining, we send for NGS. So if the tissue is available, generally a broad genomic profiling is preferred. That is a single assay or combination identifying all classic and emerging biomarkers, which we have listed before. The advantage of this type of testing is that a block is used for all the testing parallelly. It determines the clinical trial eligibility upfront when the patient is diagnosed itself. It distinguishes separate lung primary cancers from intrapulmonary metastasis, and it also assesses resistant mechanism. For example, if you have a mutation, if you have a KRAS mutation and a PDL1 more than 50%, you know that these patients are going to do bad because the KRAS is a poor prognostic marker. So that idea that it has some amount of immunoresistance, that idea you will get by upfront testing of the limited lung panel profile. Now, if the tissue is limited, you don't have the tissue for full panel testing, a tiered testing approach can be considered. Usually, we don't prefer to do this, but if the tissue is limited and repeat biopsy is not possible, you can consider a tiered approach where you check for a KRAS checkpoint mutation first. If it comes positive, then it is usually regarded that it does not overlap with EGFR, ROS1, BRAF, ALK mutation. So if the KRAS is positive, the patient may not have a co-mutation of any of other genes, is what usually regarded, but there can be exceptions. And also by this testing method, the very limited amount of tissue, the testing can be done with a very limited amount of tissue. Next slide. So this is the co-occurrence and the overlapping dynamics. So usually the actionable genomic drivers typically operate alone. That is EGFR, ROS1, BRAF, they are all alone mutations. That is, they usually don't occur 2 mutations at a time. Exceptions are MET exon 14 skipping and MET amplification can rarely occur together. Very rarely, KRAS and EGFR can overlap, and RET and EGFR or KRAS can infrequently overlap with each other. So this predictable exclusivity is the biological foundation that makes tiered tissues sparing testing safe and effective, as we have discussed earlier. Next slide. So if you have seen the NGS report, there are 2 types of classification for the reporting of the NGS. One system, it classifies the results as tier 1, tier 2, tier 3, and tier 4, in which tier 1 is tier 1 signifies strong clinical significance, tier 2 is potential clinical significance, tier 3 is unknown clinical significance, and tier 4 is benign. The second system is the reporting, where they report it as a pathogenic, likely benign, and benign. So the rule of NGS is that a variant classified as VUS should never be used to select targeted therapy, even if it occurs in a gene where other variants are clinically actionable. So you need to read the report very carefully and see what category of mutation they have labeled the mutation which is detected, what category they labeled it as. If it is labeled as VUS, you cannot select it for a targeted therapy. Next slide. So there are these are the single point and insertion drivers, namely EGFR, KRAS, HER2, and BRAF. Next slide. So coming to EGFR, the prevalence is around 15 to 50% higher in Asian population, lower in whites. And the clinical profile usually are non-smokers or light smokers. So the variant breakdown, the most common EGFR mutations are classic activating mutations, which are exon 19 deletion, which is usually seen in 45%, and exon 21 L858R, seen in around 40%. So these two combined together make around 85% of the EGFR mutations. Now, the uncommon activating mutations are S768I, L861Q, and G719X, which compromises around 10%, and exon 20 insertions, which is around 2 to 12%. Exon 20 insertions generally have very low response to standard TKIs. So in your NGS report, if you get a classic EGFR exon 19 or 21, first line treatment depends upon the type of mutation basically. So first line, it is chemo plus osimertinib or lazertinib plus amivantamab. Uncommon mutations usually responds well to second line EGFR TKIs like afatinib, and exon 20 insertions have very low response to standard TKIs. So the first line treatment is usually chemo plus amivantamab. Exception is that the variant PA763, the variant mentioned in the slide, they responds to standard TKIs. So you need to see which variant of exon 20 insertion you are dealing with to select the best possible treatment for your patient. Next slide. So this is the NCCN recommendation for the EGFR most common mutation, that is exon 19 deletion and L858R mutation. First line treatment with osimertinib or chemo plus osimertinib or lazertinib plus amivantamab. And upon progression, you need to change this treatment as per the mutation status. Next slide. The uncommon mutations, so the first line treatment is either osimertinib. Sometimes we give double dose osimertinib in this patient group, or afatinib is preferred. They classically don't respond much to first generation EGFR TKIs. Next slide. And EGFR exon 20 insertion mutation, it is usually chemo plus amivantamab as the preferred first line treatment. Next slide. Next slide, please. So coming to the HER2 and MET mutations, the HER2 is seen around 3%. The clinical profile is generally seen more in women, non-smokers, and they usually have higher incidence of brain metastasis. The key variants are exon 20 insertions or duplications, but not all mutations are activating. So NCCN usually recommends to check with the oncokb.org website, where you enter your mutation details and it displays whether the particular ERBB2 is an activating mutation or not. Coming to MET, the prevalence is around 3 to 4%, usually seen in adenocarcinomas. Clinical profile is normally seen in older non-smokers. The key variant is exon 14 skipping mutation or gene copy number amplification or overexpression. Next slide. So ERBB2 HER2 mutation, the first line treatment is songertinib and or systemic therapy, and upon progression you can consider TDXT, TDM1 or other systemic therapy options. Next slide. Exon 14 skipping mutation, the first line treatment is usually capmatinib and tepotinib, and upon progression, we change to other systemic therapy options. Next slide. KRAS, so these KRAS and BRAF are usually smoking associated mutations. KRAS prevalence is around 25%. Clinical profile is smoker, highly prognostic. As we have already discussed, it is a poor prognostic marker with a shorter survival. Key variant is codon G12C, which has targeted therapies against it. BRAF around 1 to 2% of adenocarcinoma. It can be also seen in squamous carcinomas, usually seen in smokers, current or former smokers. And the primarily studied variant is V600E. V600E patients have a 25% response rate to even single agent immune checkpoint inhibitors. Next slide, please. Can you go back? The previous slide. One more slide, previous. So KRAS G12C, the first line treatment, even if it is PD-L1 more than 1%, you direct the PD-L1 first, and then upon progression, second line, you target the G12C, that is the adagrasib and sotorasib. Next slide. BRAF 600V mutation, you can either start with BRAF targeted therapy, that is dabrafenib, trametinib, or binimetinib and encorafenib, or you start with the first line systemic therapy and upon progression you change to BRAF targeted therapy. Next slide. So the structural variants, that is the fusions and rearrangements, these are better dictated by RNA NGS because DNA NGS can miss large introns. So RNA-based NGS is critical to avoid false negatives for these fusions. The fusions we talk about usually in lung cancer are ALK, ROS, RET, and NTRK and NRG1. Next slide. ALK, it is usually seen in around 5% of cases, usually occurs in adenocarcinomas more than squamous. Clinical profile are non-smokers, and these are resistant to EGFR TKIs. The most common fusion partner is EML4. Next slide. So if ALK gene fusion is positive, the first line treatment is usually with alectinib, brigatinib, ensartinib, or lorlatinib, and upon progression, you need to change according to the type of mutation at that point of time. Next slide. ROS1, it is also very, very rare, but seen in around 1 to 2% of the cases. Usually it is seen in non-squamous, but we do consider testing in squamous variants as well. The problem with ROS1 is that DNA NGS or break apart FISH probes may underdetect the FIG ROS1 variant. So IHC has low specificity and requires confirmation. So even if you have a ROS positive by IHC, it is mandatory to do a FISH and confirm or do an NGS to confirm it. RET, it is also seen in around 2%, smokers and non-smokers. Next slide. So if you get a ROS1 gene fusion, the preferred first line treatment is crizotinib, entrectinib, repotrectinib, or taletrectinib. And progression, we change to systemic therapy. Next slide. RET fusions, the first line treatment is pralsetinib or selpercatinib. And on progression, we change to systemic therapy. Next slide. So the other two structural that fusions are NTRK and NRG1. The prevalence are very, very rare, 0.2%. And these point mutations in these two genes are non-activating. Only fusions can be targetable. So you need to check whether it is the fusion or the point mutation. For NRG1, it is even rarer and leads to inappropriate signaling in the ERBB family. The NRG1 fusions usually have large introns, and these are completely missed by a DNA NGS. So preferably an RNA NGS is preferred in this category of patients. Next slide. So NRTK fusion, if it is discovered, the preferred first line treatment is entrectinib, larotrectinib, or repotrectinib. And on progression, depending upon what was the previous therapy used, we need to change the treatment. Next slide. NRG1 fusion, we usually start with systemic therapy, and on progression, there is second line approval for senukutuzumab. Next slide. So, usually when a patient presents to us in the clinic after staging all the initial investigations, what we do is we prefer to send a limited panel NGS first before starting immunotherapy. Because if you get an actionable driver mutation, if the patient has a targeted driver, it is better to target the driver mutation first than start the immunotherapies. So even if there is a targetable driver mutation along with PDL1 more than 1%, the targeted therapy should be started first, and then upon progression, you can consider immunotherapy, because targeted therapies yield higher response rate compared to immunotherapy, and first line therapies are generally tolerated better by these patients. So targeted therapies have more toxicity than immunotherapy, and driver positive patients are less likely to respond to less single agent immunotherapies. Next slide. So initially, the tumor mutation burden was classified as an emerging immune biomarker by the NCCN, but in the latest 2026 update, it is been removed because of poor predictive value. That is, low TMB patients can sometimes respond to immunotherapy, and high TMB patients sometimes they fail to respond to immunotherapy. This we have seen in our clinical practice. And the second reason for the removal is that there is no standard cutoff. So high TMB means what is it? TMB more than 5, more than 10. There is no standardization of the cutoff. And three is that the labs are not standardized to measure TMB in a appropriate manner. So this has been removed by the latest update in the NCCN. Next slide. So the key takeaway is that usually in non-small cell lung cancer stage 4 disease, at least a broad profiling is optimal. A minimum of 10 markers are recommended by the NCCN panel. If you suspect a fusion abnormality, RNA NGS is better preferred than a DNA NGS. And the driver, if there is an actionable driver, then it should be targeted first rather than a PDL1 based approach. And all these NGS should be done in a lab with a CELIA accredited laboratory. Thank you.
Thank you, ma'am, for that excellent presentation. So we will now open the floor for participants' questions. Participants may kindly post their question in chat box.
There are no questions I see here.
Yes, ma'am.
Yeah, there are no
Can
questions.
we conclude?
Yeah. So I think I'll put down a few points before you close.
Yes.
So it's actually it was a good presentation, and everybody has put here lovely comments for Dr. Chinu. Yeah, you took that topic really well, and I think we'll discuss that topic itself first. So NGS molecular testing in lung cancer, definitely it's like it involves every month, and like 2 months I read for one of the conferences. Now again I see some more things keep coming every time. It's really good, and she's done all justice to it. So for the benefit, I would just like to recall a few points that she made very clear. So one thing very important that she told was, as we all know, tissue is an issue in lung cancer. So now with the ctDNA, liquid biopsies are increasingly being available, not so much difference in the cost. So you can always send for a ctDNA. We should do NGS in lung cancer at baseline for all the patients. And as she also mentioned, talk on the tired assessment that can be done, that if you have a KRAS, you don't expect that other mutations would be there that would be coming positive. So the patient, and if it's KRAS G12C, you have targeted therapy available for that. And as we all know, if a mutation comes in under VUS, so you don't have to target it even if a drug is available. She very well explained the AMCG tier 1, tier 2, tier 3, and how the report comes. And when you read an NGS, these are the things that you need to look at. And EGFR mutations, whether it's exon 19 or L858R or exon 20 insertion, how the drug category varies. She explained it, and here in the comments also we see that she made it so easy. So, and one more thing about ROS1, you need to confirm it by IHC. It has to be confirmed by FISH or NGS. And TMB, the thing with that was coming up rapidly, how it has gone down again. So there was no standard cutoff, and TMB has now been removed. Apart from that, there was the third talk, which was there on role of surgery in lung cancer. So we got to know through a surgeon's perspective that stage 3, how medical oncologists we see it in terms of peri-op treatment or neoadjuvant treatment versus adjuvant treatment. That is how we see operable lung cancer cases. This is how our conferences and our discussions go. And now we see the surgeon's perspective also, that what are the patients that they want to take up for upfront surgery, and how it depends based on the lymph nodes, whether they are bulky, the number of mediastinal lymph nodes, or whether they are amenable for minimal invasive surgery, and high volume centers always make a difference. Then there was the second talk, which was there on imaging in lung cancer. So this was also one of the topic, because this is our radiologist, and we always had this kind of discussion that there's something which is missing between as a link. So we should always go and discuss our things, and how we showed various CT scans and chest X-rays that we don't really see routinely in our clinics. We start with the report, and we should have a power to look at the even at the films and the images, and how it's like we just see RECIST criteria, but what is the picture when it's there, whether you have to look at the GGOs or whether you have to look at the solid part. That was something he made very clear. And as he discussed, that GGOs are the non-invasive part, the non-invasive component. So in the RECIST, it is the solid part which is the invasive component, which is which is to be measured. And how the differences that radiogenomics, how it is making EGFR, ALK, ROS, how they are working on it, the various features based on the looking at the films only, your radiologist can predict what is your NG is going to come. This is all very exciting era which is coming up. Now the first talk was on screening. It was also very well explained. So it's something which is going to pick up soon, because we have a lot of preventive teams which are going to work now, which are working and taking over, because we all know that prevention is better than cure any day. So whom should be screened? Those criteria is more than 50 years, more than 20 pack years smoking, and the old criteria that was more than 15 years quit smoking has been eliminated. So that criteria is no longer, which is a recent update. And this should be remembered that the low dose CT dose is zero point 0.6 to 2.3 millisievert. The dose itself is very low, because the patient can sometimes ask that why should I subject myself to another scan? Does this not increase my risk of cancer? So these are the answers that you need to go and give in your clinics also as a clinician. Then again, what benefit am I going to have? A smoker will ask you. So those are the reduction in lung cancer mortality that has been very well outlined. That there is a reduction in lung cancer mortality around 20% based on an LST trial. And the patient may think, why is this unnecessary invasive procedure? Am I something going with detrimental? Not really necessary. So this data was just 1.7%. So those are the figures that you can very well use in your routine clinics to to substantiate your smoking approach for a smoker to screen the lung cancer patients. And then again, apart from this, you have the risk calculators, Temenagi or BAX calculators, which would help whom to screen. You can choose those patients. And lung rats also was discussed by both our speakers. So I think this was a well discussed topic, and I don't think we have any more questions here. So I think you can wrap it up.
Okay, ma'am. So, thank you, ma'am. As we conclude today's enriching academic session, I would like to express our sincere gratitude to our distinguished Program Director, Dr. Akanksha Chaudhary, and all our esteemed speakers for sharing their valuable expertise and time. We also extend our heartfelt thanks to all the participants for your active participation. We hope today's session has enhanced your understanding of the evolving landscape of lung cancer management. On behalf of the International Association for Integrated Oncology, IAIO, thank you for joining us again and have a wonderful evening. Stay safe and we look forward to welcome you to our upcoming IAIO academic programs. All the participation will be receiving their certificate within 2 to 3 working days to your registered mail ID. Thank you. Good night, everyone.